Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today or in the future. My name is Rebecca and I'll be facilitating today's webinar, the 21st Century Revival of Therapeutic Research on Psychedelic Drugs, Rationale, Evidence and Potential Future Medical and Other Uses. This webinar is a part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. This webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We want the webinars to be as interactive as possible. Please ask questions, but do so via the Q&A function. I'll be collating those questions and we'll ask our presenter at the end. Please be aware that our webinars are recorded and they will be made available later on our website should you need to leave early. We encourage you to stay to the end of the webinar and complete the exit survey, which will come up on a QR code on the final slide. And you'll also receive an email. Our presenter has kindly agreed to share copies of the slides, which will be forwarded to you again via email. Today, I'd like to introduce Wayne Hall, Emeritus Professor at the National Centre for Youth Substance Use Research at the University of Queensland and the Queensland Alliance for Environmental Health Services. Wayne has worked in both Australia and the UK and has provided advice to the World Health Organization on the health effects of cannabis use, the effectiveness of drug substitution treatment, the contribution of illicit drug use to the global burden of disease, and the ethical implications of genetic and neuroscience research on addiction. Wayne, thank you so much for joining us today.
Thanks for the invitation to speak, and I begin by acknowledging the traditional owners of the land from which I speak, which is Meanjin. The traditional owners here are the Turrbal and Yagra peoples. I acknowledge their elders and any First Nations people listening to this talk. So the talk I'm giving here is basically my COVID project. In the lockdown, I ended up doing a lot of reading on this particular topic, and that's reflected in the presentation that I'll give today. So first, some declarations of interest. I don't have any financial interest in any companies that are developing psychedelics, but in the distant past, I was a signatory to an amicus curiae brief to the US Supreme Court when it was considering the religious use of ayahuasca by a Brazilian religious group. And I've collaborated in the past with two British researchers who are leading work on psychedelics, although I have not worked with either of them on this particular topic. I guess countervailing that which might seem, those two interests that might be seen to dispose me to being positive is I'm much more sceptical than many of the advocates, in part because I'm sceptical about all therapeutic claims. And I think more specifically, I'm chronologically gifted enough to have lived through the first psychedelic era in Australia, and I remember it rather than reading about it as many people nowadays do. So I'll say something briefly about the European discovery of these plant-based drugs, which, as you'd be were well known to Indigenous peoples in the Americas. I'll talk briefly about the history of the medical uses of these drugs in the 1950s and 60s and make the point that, in fact, the first therapeutic uses of psychedelic drugs were in the treatment of, as it was then called, alcoholism or alcohol dependence back in the late 1950s. I'll talk a bit about why the research ended in the US in the 1970s and make the point that it's not simply a matter that LSD and other drugs were casualties of the war on drugs. There are a whole lot of other factors that contributed to this. And I'll talk about reasons for the renewed interest in their therapeutic use since the beginning of the early 2000s, and end by talking about some of the issues around how we should regulate these drugs for medical use if the clinical trials produce the evidence that the regulators accept warrants their clinical use, and how we might manage their non-medical or adult use outside medical control or supervision. I think the first thing to make is that the concept of a psychedelic drug is not a well-defined one. This very long definition goes back to Lister Grinspoon and James Bacala's book on psychedelic drugs reconsidered at the end of the 1970s. And they're trying to capture some difficult features about these drugs, the effects of which have often been described as ineffable, that is difficult to describe in words. And what they're pointing to are fairly profound changes in thought, mood, and particularly perceptual experience of the sort that most of us only experience when we're dreaming, or in those rare occasions if people engage in contemplative or religious experiences. But these experiences are in the absence of physical addiction, craving, or any of the other typical features that we associate with addictive drugs. What's included in these categories is also not well defined. The so-called classic psychedelics were LSD, psilocybin, and mescaline. But there's a variety of others that are often included in this broad label, such as MDMA, which lacks a lot of the perceptual effects of the more classic psychedelics, and drugs like ketamine and DMT, which is found in the ayahuasca plant. The classic drugs produce these profound visual pseudo hallucinations and synesthesias, where we see colours and where we hear colours and so on, and often produces a range of so-called oceanic feelings of ego dissolution and ineffable mystical experiences. The best studied of the classic drugs are the LSD and psilocybin, and these appear to act on a specific serotonin receptor, the 5-HT2A receptor. And we know that because the experiences of these drugs can be blocked by giving drugs that are antagonists to that particular receptor. But it's also clear that the effects of these drugs are not confined to a single receptor or a single receptor system. They act on a wide variety of neurotransmitter systems in the brain, which is one thing that makes them very interesting to neuroscientists, of course. So the first of the psychedelics that Europeans chanced upon was mescaline, which comes from the peyote cactus. And this was identified and synthesized in the 1930s and produced a lot of excitement back then. The psychiatrists took it and described their experiences in journal articles. And a lot of people remarked on the similarities between the experiences this drug produced and the experiences of schizophrenia or other psychoses. So there were a variety of psychiatrists who proposed that this suggested that schizophrenia was the result of a toxic amine, that is some drug that formed in the brain that produced very similar effects to, say, mescaline, and was responsible for producing this particular disorder. Osmond and Hoffer were two psychiatrists who thought that they'd identified this toxic amine as adrenochrome, a metabolite of adrenaline, which they claimed produced psychotic symptoms that could be relieved by giving very large doses of niacin. But other researchers weren't able to replicate their findings. They couldn't reliably produce psychedelic effects by taking this particular drug. They couldn't find evidence of its presence in the serum of people with schizophrenia, and they weren't able to replicate the claim that large doses of niacin reduced psychotic symptoms. There was much stronger support for an alternative theory of psychosis, the dopaminergic theory, which emerged around the same time, largely prompted by the fact that there were cases presented by Connell in the late 1950s of people who had been taking very high doses of the drug methamphetamine who developed auditory hallucinations and paranoid ideation. So this was the alternative theory of psychosis that largely displaced the idea that it was caused by toxic amines. Earlier, in the late mid-1940s, lysergic acid diethylamide, or LSD for the rest of us, was derived from the ergot fungus by Hoffman, who inadvertently dosed himself with LSD and experienced an unplanned trip. He later deliberately reproduced the experience by taking a dose that we know to be a lot larger than that's required to produce these experiences. And the drug was patented by Sandoz, the company he worked for, and they provided free samples of the drug to psychiatrists for use in what was called psycholytic psychotherapy, which was a psychodynamically based therapy in which the drugs were used to access unconscious material and work through various traumas that patients had experienced. It was also suggested that it would help psychiatrists better understand the experiences of their patients who developed psychosis. Around the same time, psilocybin was isolated from mushrooms, and again, Hoffman was the person who isolated the mushrooms that were provided by a Mexican healer, and he later returned to Mexico and gave the psilocybin to this particular Mexican healer, who confirmed that its effects were, in her view, the same as those of the mushrooms. This is a sort of example of the very bad psychedelic art. That's Hoffman, the synthesizer of both those drugs. These are, of course, the mushrooms that produce the psilocybin. As I said, I think in the introduction, the first therapeutic use of psychedelics was in the treatment of alcohol dependence. And this was undertaken, or at the suggestion of Humphrey Osmond again, who'd relocated to Canada, to the province of Saskatchewan, and was running mental hospitals there, which had thousands of patients. They were well and truly overcrowded. And a large group of the patients in these hospitals had chronic alcoholism. And this was back in the period when people went into mental hospitals and didn't come out. So they'd typically be hospitalised and kept in there for long periods of time. They were under pressure from the government to reduce the numbers of patients in hospitals, and they were looking for a treatment for alcohol dependence. Osmond and Hoffa thought that they could scare alcoholics into sobriety by giving them LSD and producing an experience a bit like delirium tremens, and that this might well motivate them to become and remain abstinent. They gave it to 2 patients, and this is what's interesting about this particular one. Osmond and Hoffman only treated 2 patients themselves. All the other patients were treated by junior doctors working in their hospital. It was 1 man and 1 woman, and they found that these patients didn't report frightening experiences. They, in fact, reported mystical experiences or epiphanies in which they decided that they really needed to stop drinking. And Osmond and Hoffa then described this approach as psychedelic therapy, which involved using fairly high doses of LSD on the assumption that people who were alcohol dependent were pretty tolerant to the effects of these drugs, with the aim of producing mystical experiences. And they very, very strongly encouraged people to enrol in AA after treatment. And they followed up these 2 patients and reported that half of them were still absent 6 months later. The younger colleagues ended up treating some probably 100 or more patients with this particular approach, and were reporting fairly positive results as well. These results were reported in a number of journal articles and were met with a pretty strongly sceptical response from people in the field at the time, who pointed out that they were uncontrolled studies, very small numbers of patients, no comparison group, and the abstinence was entirely self-reported, and so the results depended critically on the veracity of the patients. And they was fairly suspicious of the clinicians, all of whom had used LSD, and some of whom used LSD with their patients during these sessions, and also sceptical about the claim that psychedelic or mystical experiences were essential for success. Interestingly, the local AA community in Saskatchewan were very positively disposed towards this approach, which they saw as basically helping people get a jump start to the first couple of steps on the 12-step ladder. But it wasn't a view that was shared by AA members elsewhere in North America. Interest in this particular approach declined during the 60s as randomized controlled trials were performed. This had become a requirement of new drug treatments from the early 1960s in the US, for reasons I'll explain a little later. And the randomized controlled trials of this approach did find greater abstinence at 3 months in the patients given LSD compared to those who were given either no drug at all or a placebo. But the longer they were followed, the smaller the differences, and certainly by 12 months in most of these trials, there were no longer any difference in treatment outcome between patients given the LSD and those who weren't. And as I mentioned earlier, the traditional AA opposition to the use of psychoactive drugs in the treatment of alcohol dependence really meant that it didn't get traction in the self-help community either. More recent meta-analyses of these trials have been done and published, and they largely confirm that in the short term, LSD did produce better responses in terms of the number of patients who are abstinent or reductions in alcohol consumption, but these differences largely disappeared by 12 months of follow-up. The other big thing that happened that Osmond was connected with was the initiation of the author Aldous Huxley into psychedelic drugs. Hoffman gave Huxley mescaline on a visit to Los Angeles in the 1950s. Huxley wrote a very influential book called The Doors of Perception, which largely advertised the mystical experiences that these particular drugs produced. And that sort of started another thread of interest in these particular drugs amongst people interested in exploring alternative realities and perception. Huxley's essay advocated for the use of mescaline for spiritual experience, and his description of the experience probably had a big impact on the set of many people who subsequently tried using these drugs. He described it as bypassing the cerebral reducing valve and suggested that these drugs would provide a less harmful alternative to alcohol and tobacco, as he described it, a chemical vacation from intolerable selfhood. Huxley later moved to using LSD, as did Hoffman and others, and they used much smaller doses of this drug, and patients reported fewer adverse effects. Use became very widespread. Henry Luce, who was the publisher of Time magazine, became a fervent advocate, and his magazine published lots of very positive articles on the virtues of psychedelic drugs. The actor Cary Grant was a celebrity endorser of LSD, given his own experiences in therapy. And there are a lot of people in Silicon Valley who used LSD who've since funded, as we'll see, more recent research on these particular drugs. Huxley advocated what might be described as a trickle-down theory of psychedelic enlightenment, that the people who should be given these drugs are those who are running the country, and they would be enlightened, and the enlightened will trickle down into the broader community. But of course, there are other people with other ideas, foremost among them people like Timothy Leary and Ken Kesey, who were all for getting LSD and psychedelics out into the broader community and advocating their widespread use. Leary started off as a Harvard professor, giving these drugs under some sort of control conditions, but became a pretty fervent advocate and was persuaded or encouraged to leave Harvard, after which he then began to promote LSD as a religious sacrament. Ken Kesey, the author of One Flew Over the Cuckoo's Nest, was on the West Coast. He was even more into freaking freely, using LSD for fun, and conducted large-scale electric Kool-Aid acid tests described by Tom Wolfe in a book of that name. It also got into popular music, groups like The Doors, Jimi Hendrix, the Beach Boys and the Beatles. And in part because of this widespread enthusiasm, California was the first state in the US to ban LSD in 1965. The response to which, of course, was large-scale illicit production by the character Augustus Owsley Stanley III. And later on, as we'll see, there was federal prohibition of cannabis in 1970 under the Controlled Substances federal prohibition of LSD under the Controlled Substances Act, along with cannabis. That's Kesey, another example of the sort of colour sense of the psychedelic pioneers, perhaps. Hunter S. Thompson, Leary, and various others. And of course, the Sgt. Pepper's album, which was inspired by a lot of psychedelic art. Of course, there was an unsavoury side to the psychedelic movement in this period, the most infamous of which was Charles Manson, who used LSD to recruit runaways in San Francisco, who relocated to Los Angeles and whose followers committed a series of fairly gruesome murders there in the late 1960s. The criminal trial in 1970 did a lot, I think, to move public opinion against LSD and psychedelic drugs because of what Manson and his followers got up to. But he wasn't alone. Less well known, there's an Australian cult, in fact, in Melbourne, in this case run by a woman, Anne Hamilton Burns, who persuaded her followers that she was a reincarnation of Jesus Christ. And again, LSD was used, in that case prescribed by a psychiatrist who was authorised to use LSD for therapeutic purposes. Carlos Castaneda published a whole series of best-selling books, allegedly on a Yaqui savant and healer, which was subsequently exposed to being plagiarised from the anthropological literature. He also founded a cult whose members committed suicide after his death. Less well known is the Weather Underground, which was a group of, I guess, left-wing bank robbers and others committed to acts of violence against the US state, were keen users of LSD. And in fact, they sprung Timothy Leary from prison when he was in prison for a cannabis offence in California. The other group, the Rationale, or the Orange people, used MDMA, and the breakup of that group in Oregon in the early 1980s led to its dissemination amongst followers into Europe, and is often credited with introducing MDMA to the dance party scene in London and Spain at that time. And it wasn't just the people into peace and love. The US military and the CIA were also doing clandestine research on LSD, prompted in large part because of the Korean War brainwashing fears. And they're also interested in using it to interrogate spies and disable enemy forces. And they funded some of the research on model psychoses. The CIA conducted some really egregiously unethical research, giving LSD to people without their knowledge or consent. The worst case in brothels in San Francisco and New York that they set up for that purpose. The Army also gave LSD and other drugs to enlisted men. And there were certainly people, there were at least one suicide death in the people given LSD by the CIA, and there were other legal cases brought by members of the Army who'd been given the drug during their service. So why did research cease? Well, as I indicated earlier, it wasn't just because the Controlled Substances Act classified LSD and other drugs along with heroin, cocaine, methamphetamine and cannabis. There were a whole lot of other things going on that preceded that, one of which was the tightening of clinical research after the thalidomide scandal. In the 1950s, any clinician could do research, or what was described as clinical research, by getting a drug from the drug manufacturer and giving it to their patients to see what happened. And this is in fact how a lot of drugs were investigated in the 50s, not just LSD, but also early work on lithium for the treatment of psychosis, chlorpromazine, and the tricyclic antidepressant drugs. This changed after 1963 when the US Congress tightened up regulation of new drugs, in large part because of the thalidomide scandal that occurred in Europe, hadn't occurred in the US because the FDA had not given approval for the drug to be used there. But this required a clinical trial notification, animal safety data and evidence from randomised controlled trials that the drug was safe and effective. So the level of difficulty in doing controlled trials went up very, very quickly. And given that a lot of the early work was done by people working in mental hospitals, they didn't have the infrastructure or experience or knowledge to do these sorts of clinical trials. In 1965, Sandoz also decided to get out of the business of supplying LSD and psilocybin for trials. It did agree to fund or to provide drugs for NIH-funded university clinical trials, but it was largely concerned that patents the drug had expired, so they weren't about to make any money from them, and they were very worried about their reputation given the activities of Timothy Leary and others at that particular time. But there are also other factors. There were examples of malpractice with the use of these drugs being reported in California as early as the 1950s. People in private practice giving them to patients who had psychoses and them turning up in emergency departments and requiring treatment. There were case histories of suicide attempts and so on. Many of the advocates for the therapeutic use of this developed what's been described as irrational exuberance about the effects of the drug. And there was also what's been described as the snigger factor, the fact that if you expressed an interest in doing research on these drugs, then your peers tended to sort of want to avoid you because the suspicion that you might end up turning into Timothy Leary. But it is worth noting that research didn't end in the 1970s as commonly claimed. NIH funded research into the early 1970s, and the state of Maryland, in fact, funded a clinical research centre that conducted clinical trials on these drugs until 1979. So the ending of research was a more gradual process than has sometimes been suggested. So what about the recent revival of interest in these drugs? Well, there's some continuities in personnel. Rick Doblin, who's been leading a lot of the work, particularly on MDMA, and Bob Jesse, who's been funding quite a bit of work as an earlier IT pioneer who had used the drug in the late 1960s. Both have had what they described as transformative personal experiences with the drugs and were convinced that they had therapeutic use, and they had the money to fund at least small-scale trials of this particular research. They were also able to recruit what was different from the early research. They could recruit well-qualified researchers in the major universities in the US, UK and EU who had the training required to do the clinical trials on these drugs to the standard required for approval by the FDA, and also the infrastructure to do neuroimaging studies, the mechanisms of the action of these drugs. And so a lot of this research has been published in very high impact peer-reviewed journals like Nature Medicine and the New England Journal of Medicine and Lancet Psychiatry. So what's the research shown? Well, since the mid-2000s, what might be described as very promising results in small sample clinical trials, particularly initially for psilocybin for anxiety in the terminally ill and intractably depressed, and Doblin's work on MDMA to treat post-traumatic stress disorder. It's around this time that the neuroimaging research on the mechanisms of action of these drugs began to be done, initially with an interest in exploring mechanisms of consciousness, but also then looking particularly at how the drug acts on the 5-HT receptors and how this might change brain networks and function. Also around this same time, there were a group of historians who published sympathetic reappraisals of the earlier psychedelic research by Osmond and Hoffer. They measured it against the standards of its day and have been critical about the reasons for why the research was abandoned. I think the other factor is the very popular book, Michael Pollan's book, How to Change Your Mind, which I think is now a Netflix series, which has excited a lot of interest in the broader community, but also amongst researchers in these particular drugs. So what people have begun to do, and where most of the work has been done, has been on psilocybin rather than LSD, and this is in part for pharmacological reasons. It's a shorter period of action, so it's more manageable to run a therapeutic session over half a day than the better part of 24 hours in the case of LSD. Simpler pharmacology that's better known, people have fewer bad experiences, and critically it lacks all the cultural baggage that LSD carries. And it's been investigated most extensively in the case of depression and anxiety, but we're beginning to see now trials in alcohol-dependent smoking and obsessive compulsive disorder. The FDA was impressed enough with the results of some of these early trials to encourage the conduct of larger scale trials in depression and using the incentive of characterising it as a breakthrough drug, which makes it easier to do trials and to get the drug approved. There have been very similar results in the studies of MDMA-assisted psychotherapy for PTSD, again, with the FDA signalling that it's very interested in expediting the approval process. I should stress in both these cases the treatment program as a package in which the drug is given in combination with psychotherapy, often fairly extensive, particularly in the case of the MDMA assisted psychotherapy, and I think sort of 10 to 15 hours of psychotherapy time involving preparatory sessions, the drug sessions, and then sessions to go over the material that's been produced in the session. And there's also been a lot of interest in doing neuroimaging studies of the effects of these drugs by the group at Imperial College. So what's difficult about doing research is obviously it's difficult to disguise from people who've been given a psychedelic that they've been given a psychedelic. The placebo controls just don't work in this particular case, which makes the blind assessment of outcomes and longer-term follow-up of these outcomes very critical. So the RCTs have all been positive, but they've all been conducted by people who are advocates of the therapeutic use of these drugs. So a lot of sceptical people, including myself, want to see these results reproduced in larger studies by less committed researchers. And this is, I think, with good reason, because new treatments are always at their best early in their introduction. Trials are small, researchers are enthusiastic and hopeful, and patient selection tends to favour new treatments, e.g. by excluding people with comorbid disorders. And those who are old enough to remember the introduction of SSRIs can remember very similar hype surrounding the introduction of this class of antidepressant drugs in the 1990s. So we've heard similar sorts of stories before, which is why people tend to be a bit sceptical. So there's also, I won't go into the detail, I'm happy to answer questions, but there are larger clinical trials which are finding reasonably positive results up to 12 months in the majority of cases, and there's been a recent trial published in the New England Journal of Medicine Compass trial, which is largely just looking at the effects of a single dose of psilocybin rather than the psilocybin in psychotherapy package that's been trialled elsewhere. But this study found clinical remission rates, which I think are much more plausible, much lower than the more positive trials, but still certainly something that would be of interest to many patients with depression, which has not responded to conventional treatment. Oops, I'm stuck here. Very similar rationale. I won't go into details around the MDMA and PTSD because I'm going to focus more on the recent work around the use of these drugs in treating alcohol dependence. But broadly stated, the results of a lot of this approach to treatment have been similarly very positive, and there's a lot of optimism that MDMA will be approved by the FDA within the next year or two. So what sort of research has been done on psychedelics in the treatment of addiction? Researchers have used psilocybin, DMT and ayahuasca in small-scale studies, usually small samples, open label studies, meaning that the patients know what they're getting. There's no comparison group and short-term follow-up, but all report good abstinence, high rates of immediate abstinence, and there's been a lot of interest in funding larger scale trials to get FDA approval. And I'll just talk about two very recently published trials, one from the US and the other from the UK. This was Bogenschultz and colleagues who compared psilocybin with diphenhydramine as the placebo. I don't think many of their patients were fooled, but they combined the drug with a controlled trial of motivation enhancement therapy and a more traditional CBT. They studied 95 participants. Thanks to COVID, they weren't able to recruit the 180 that they would have liked, that they originally intended to collect. And their primary outcome was percentage of heavy drinking days at a 32-week follow-up. And there was a substantial reduction in the psilocybin group, larger than in the controls. The limitations were the study was underpowered because of COVID and the blinding of the participants, and to some degree the therapists failed. So the authors were circumspect about not wanting to claim too much and largely argued that the results made a good case for a larger scale randomised controlled trials. A more recent study by Celia Morgan and colleagues on ketamine and the treatment of alcohol use disorders, which was presented at the recent APSAD meeting in Darwin. This was a double-blind trial of adjunctive infusions of ketamines in people with alcohol use disorders. They had 96 patients who'd withdrawn from alcohol who were randomised to this factorial design that combined infusions of ketamine with alcohol educational psychotherapy and infusions of saline with the same sorts of approaches. The psychotherapy consisted of mindfulness-based relapse prevention, and at 6 months follow-up, there were more days of abstinence in the two ketamine groups. And the highest rate of abstinence was observed in those who received the ketamine and the psychotherapy. Again, there were no serious adverse events, and again, the authors were careful to not overstate the claims that they made and were largely arguing that this justified the need for much larger trials to evaluate these treatments. So how safe are these approaches to treatment? Well, as often said, adverse events in the 1960s were rarely reported in medical use, but there's some concern that they might not have always been reported. Doblins reported in a follow-up of the Good Friday experiment that one of the patients in that, these were the people given LSD to induce a religious experience, one of them developed psychotic symptoms that required the use of an antipsychotic drug. Adverse events were obviously much more common in non-medical use in the 1960s, and this is where we see case reports of psychosis, suicides, and accidental deaths. Prevalence of these is probably low given the large denominator of users, but if you get unselected groups of people, particularly people with pre-existing psychiatric disorders, giving them LSD in an unsupervised way, then you have to expect these sorts of adverse events to occur. There was also allegations that LSD produced genetic effects that were not supported by better designed studies. More recent studies of recreational users report few adverse events, and it's not really clear why this is the case, whether people are using much lower doses, there's better preparation, people are much better informed, or whether there's some sort of selection effect going on in surveys that people with better mental health are more likely to report, are more likely to experiment with these particular drugs. Adverse events have been relatively rare in clinical trials and laboratory studies, but the caution here is that a lot of these trials have excluded risky patients, people with a family history of psychotic illness, for example, or any previous psychiatric history. So they may be a bit optimistic about what might happen when the drugs are used in unselected patients. So the main limitations, I think, are fairly clear to date. A lot of the studies have used small samples, a lot of them have been crossover studies, limited numbers of investigators, mostly advocates. And the funding has been difficult until recently because pharma companies and government have not been prepared to fund it. That's changed very recently. There's a lot of pharma interest in these drugs. There's funding coming for large-scale trials. And here in Australia, the federal government has allocated, I think it's $15 million for clinical trials of psychedelics. So we're in a much better position to do the larger scale trials that remain required. We still don't know a lot about the mechanisms of treatment, why it is that 1 or 2 doses of psilocybin appear to produce sustained remission in depression. A lot of the attempts to explain it are little more than metaphors about resetting the brain or the default mode network. It's clear that set and setting are critical. It's not simply a pharmacotherapy. It's a pharmacotherapy given, in the context of psychotherapy. And there's debate about what role is played by spiritual experiences. Are they causal? That is, are they required for the experience of clinical benefit, or are they an epiphenomena? That is, an indication that someone's got a large enough dose to produce therapeutic change. And you've got people who argue it doesn't matter anyway if they're drug-induced delusions, if people's mental health is improved. So are they likely to be approved for medical use? I think it's quite likely that the FDA will approve. They're certainly making all the right noises. The clinical trials are being done to their satisfaction. And the question will be, if they are approved, is it only as a a treatment for intractable depression, or will they be used as first-line treatment? Will it be possible to stop them being used for first-line treatment if they are approved for clinical use? And who will be allowed to prescribe them? Will it be psychiatrists only or any family doctor? The other issue that's often raised is the expense of these treatments. Certainly the Rolls-Royce model of MDMA-assisted psychotherapy with 15 plus hours and 2 co-therapists and lots of time is something that might be paid for by the Veterans Administration for veterans with PTSD, but if you're paying for it in the private sector, that might be a little expensive. So there may well need to be attention given to reducing the amount of the duration of these treatments so it could be more easily scaled to up to scale necessary to make a difference at the public health level. I think the concern here is that we're at risk of following the example of medical cannabis and getting well ahead of the evidence. Compassionate access before clinical trials have been completed will, I think, reduce the incentive to complete the clinical trials and will also increase the chances of misadventure. So we've got the TGA here has very recently approved the use of psilocybin and MDMA for depression and PTSD, respectively, under the Special Access Scheme. This means that it can be prescribed as an unapproved therapeutic good. They've attempted to restrict who can prescribe to psychiatrists and require that the psychiatrists are authorised prescribers and that they have ethics committee approval or the approval of the College of Psychiatrists. So there's an attempt at the moment to allow compassionate early access here in Australia, but to control it. The question is how long that control can continue under the pressure I think we'll expect to see from patient advocates to make it much easier to use these sorts of treatments, particularly for anxiety disorders, addiction, post-traumatic stress and terminal illness. And I think we'll also see pressure to authorise the compassionate use of other psychedelics, and including whole plants, because we're hearing more already about the alleged entourage effects of the psychedelic plant as against the pharmaceutical drug extracted from them. And I think there'll be also large questions about whether, to what degree, the non-medical use of psychedelics will be allowed for microdosing for wellness and creativity or for spiritual exploration. Because this is now happening in the US, where there's been recent referenda to allow the use of psychedelics outside medical supervision in Oregon and Colorado. And I think the concern I have, having lived through the first psychedelic enthusiasm, is that we might see a renewed irrational exuberance about these drugs. And I think the big risk is patients are very suggestible during the psychedelic experience and particularly after taking it. And there's a temptation for therapists to become gurus and for patients to treat their therapists as gurus and to produce very radical changes in epistemic beliefs. Now, there's a tendency, I think, in the literature to think that that's going to make people more green and appreciative of their environments and supportive of strategies to reduce global warming. But there's some worrisome anthropological research from Europe about right-wing extremist groups using psychedelia to promote their own brand of crazy beliefs. And there's also experiences already of the sexual abuse of patients undergoing treatment with these drugs, including in one of Rick Doblin's trials, and more recent accusations about people who are engaged in the non-medical use of these. So you can certainly see a return of the therapeutic grandiosity that we saw back in the 1960s, that the view that psychedelics will change the world and cure humanity's ills and stop war. And to the degree to which we see that, I think we might end up producing a very similar public backlash against the use of these drugs for good therapeutic purposes and see more restrictions on non-medical use. I think I've already mentioned some of what's going on there, so I'll just quickly throw up, these are in the presentation, these are some short articles I've published on the topic. And the bottom one is a longer document which can be downloaded from the NDARC website, which largely covers the material that I've talked about in this talk. And here's the final slide, which I think you're encouraged to use the QR code to complete a survey for feedback. I'll stop there. So we've got, I think, about 15 minutes for questions, because I know I've covered a lot of territory in the 45 minutes that I've spoken.
Thanks so much, Wayne. I do have a number of questions for you. I think perhaps this question came up before some of your final slides. How strong is the cultural baggage of LSD, and is there still a snigger factor?
I think LSD does still carries a fair amount of baggage, but there has been a renewed interest in it. There are now clinical trials being done using LSD and others that are proposed. I think the snigger factor is still there, but I think, to be fairly crass, money makes a big difference. If there's 15 million out there for clinical trials, there's a larger group of people who become interested in doing research on these drugs, and I think that's a good thing. I think while the research has been until now largely conducted by people who are advocates, that sort of creates suspicion, and I think the extent to which research is conducted by non-advocates and to the degree to which they reproduce the very positive results of these early studies, that will probably be to the good in changing or reducing the snigger factor.
Thank you. Can you please share more of your personal skepticisms and concerns around the efficacy of psychedelic drugs as a treatment for mental health issues?
Yeah, I mean, as I said earlier, I graduated from high school in 1968, and I was at university from 1969 to 1977, and in the early 1970s, LSD and the magic mushrooms were all over the place on the campus where I did my training, and I saw a lot of people not so much come to serious grief, but end up believing very silly things, I think, and that got in the way of them, at least for a time, sorting out their lives. So that's been the worry. And then if the drugs are used under supervision by people who know what they're doing, and patients are carefully screened, then I think they can be, they do look like they could be very useful, particularly in depression and PTSD. I think the concern is if they get out into the wild, they're used outside medical practice, or they're used by people taking shortcuts who are mainly interested in making money from them, then we're likely to see misadventures, people getting into serious stress. So if someone with a psychosis is given these drugs and they're not supervised, then their mental illness could be made a great deal worse. And there are a couple of case histories recently been published of people with these sorts of experiences in the US as well. So that's the reason that I have for concern about the use of these drugs if it's not done in a very controlled way. I mean, I think the media hype about them is probably not doing a lot of good in terms of, will be encouraging a lot of people who have a serious mental illness to think that they can take these drugs without medical supervision and to treat their problems. And I think that's when, if we see people turning up in emergency departments and mental hospitals with serious adverse effects from these drugs, then that's when restrictions on their use might well be increased.
Thank you. When you referred to some alleged genetic effects, and we've got a viewer wanting to know what they were.
Well, it was a very early study done. It was a pretty poorly done one, which where they looked at chromosomal damage in people who'd used LSD. And this was, remember, this wasn't that long after thalidomide. So this got enormous media coverage, and it was used by people who wanted to restrict these drugs and ban them as a case for doing so. So they're saying not only these drugs drive young people mad and commit suicide, they cause genetic damage, and so we've got to ban them. the group in Maryland that were doing the clinical trials then did a much larger study looking at chromosomal changes in people given these drug therapeutic purposes and couldn't replicate the results in the early studies. But of course, that the study that failed to replicate was published well after the earlier study. So, and in the meantime, the Controlled Substance Act had been passed and they've been banned.
Thank you. Do you think there will be clinical trials in Australia for substance dependence?
I'd be surprised if there weren't. I mean, I'm not that well in touch with various groups. There's John Marsden from King's College London was just giving a talk here in Brisbane last week on a trial that they're planning to do at the Institute of Psychiatry. And I know there'd be a lot of interest, particularly in the addiction field, in doing similar sorts of trials here for alcohol dependence and other forms of dependence. If the funding is there, so it shouldn't be difficult to do that. When I think the worry in this area, as with the medical cannabis, is if lots of people pile in and want to do clinical trials, you end up with lots of small clinical trials that don't end up telling you much. So I think it'll be critical, if they are done, that they're large enough to be informative and that they use reasonably representative samples of the sorts of patients who might be given the treatment if it is approved for clinical use.
Thank you. Is there any evidence that you're aware of for the use of psychedelic-assisted therapies in the treatment of anorexia nervosa?
Not that I'm aware of, but I guess there's a lot of comorbidity in sort of depression, anxiety, in people with eating disorders. So it's not beyond plausible that they might have a role. But I wouldn't think that they should be a high priority there. But I guess part of the interest in these drugs for conditions like that, and even I'm just today was working on a commentary on a proposal to trial psychedelics in the treatment of Alzheimer's dementia. When you've got serious psychiatric and neurological diseases where there aren't effective treatments, it's understandable that desperate patients and their families will look to these drugs as a possible cure. I think there should be a better base, evidence base for doing clinical trials in these conditions rather than nothing else works, so let's give it a try. And I think there'd be a bit of that sort of desperation about anorexia, as there is even more so with Alzheimer's dementia, I think.
Thank you. You mentioned earlier the entourage effect of psychedelic plants. I'm just wondering if you can explain that a little bit more.
Yeah, people may have heard about the entourage effect in the case of medical cannabis. And this is the argument that in the case of cannabis, it's THC and CBD, that when you isolate those cannabinoids and give the pure cannabinoid to patients, you're emitting all sorts of other things that are found in cannabis plants, terpenoids and other minor cannabinoids, and that the whole package may well have a bigger therapeutic effect than the isolated components from it. I don't know that there's any good evidence to support that. It's a popular claim that's out there, and it's largely used by people to justify the use of plant-based cannabis medicines rather than pharmaceutical medicines. We're beginning to see a similar sort of argument put around psychedelic drugs. I think it's harder to run it in the case of psilocybin because psilocybin is the active ingredient in mushrooms. I don't know that there's any evidence that any other components there produce the same effects. LSD, of course, is a synthetic drug that comes from ergot, a sort of plant-based mold. It's more often advocated, I think, in the case of mescaline, the peyote cactus, and the ayahuasca, the sorts of plant-based drugs from Brazil that deliver DMT and various other components. I mean, it's an empirical question in a sense. You do clinical trials and compare the effects of the plant-based preparation with a pharmaceutical one and see if it makes a difference. Studies have been done on cannabis in that way, which have really failed to find any strong evidence of the entourage effect. But it's a popular view that's out.
Thank you. Which drugs do you believe show the most promise for AOD treatment, and what trials do you think we might see in Australia?
Well, I think probably the shorter acting ones, the psilocybin, MDMA, and I was surprised by the ketamine results that Celia Morgan did point out that there'd been quite a bit of work on ketamine done in Russia back in the 1990s, I think it was, for alcohol dependence. It's not clear why drugs with such a variety of very different pharmacological effects should be useful, but again, it's an empirical question. If it's about sort of encouraging people with serious alcohol and other drug problems to have the required epiphany that helps them realise that they really can live without using the drug and all the damage that it's doing to them. I just don't know. But probably the shorter acting ones, the ones I listed, would be the more promising. But the London group are trialling a very short acting drug, which I think is related to DMT. It's even much shorter acting than the psilocybin and MDMA.
And why isn't there physical dependence on psychedelics? Is it just a case of people don't use them as often?
Yeah, I mean, that's an interesting question. I mean, Timothy Leary claimed to have used LSD every day of most of his life. You can sort of take from that whatever you like in terms of whether it's a good thing or a bad thing. When people don't appear to develop withdrawal symptoms, when I think there's some degree of tolerance develops to these drugs, and that's well known with MDMA that you need to take breaks from them to re-experience the full effects of the dose. But yeah, I think a lot of people's curiosity, particularly around the psychedelics, and that was certainly the experience when I was at university. Most people probably had a handful of experiences and didn't really repeat it or go looking for repetition of it.
Thank you. I think you've in part answered this, but what are the top 3 reasons you remain on the skeptic side, based on what you've seen about cannabis progressing before in regards to research? What can we learn from that?
Well, I think once a drug, I mean, if you create a system for distributing a drug that's unapproved in the absence of evidence of efficacy and safety, which is what was done for cannabis, then you remove any incentive for people to do serious research. And you create a business, basically, for people to promote the use of these drugs for anything and everything, and to make large profit from it. And I think we're seeing that to a degree with the sort of the proliferation of medical cannabis clinics. There's similar concerns expressed in the US at the moment about ketamine clinics for depression. There's a lot of for-profit entities that have been set up that are dispensing these drugs using telemedicine. They're just basically prescribing them over the internet, not really supervising the use, not really providing the necessary follow-up for patients. So those are the concerns, not so much about the efficacy as the fact that these drugs will be allowed into clinical practice in the absence of good evidence on who's likely to benefit from these drugs, how they should best be used, and how we can protect or minimise any adverse effects of their therapeutic use.
Thank you so much, Wayne. I'm just aware of the time. Got a number of messages just thanking you for a great presentation, and the historical overview was really helpful. Thanks again for your time. Thank you, everyone, for attending. Just a reminder about the QR code, and Wayne's presentation will come to you via email. Thank you.